We recently heard from someone, let's call them a concerned child. They've noticed their aging parent has had a couple of falls recently, and, well, there are also some worries about memory.
Mm-hmm.
They reached out hoping we could help them sort of get a handle on the medical articles and, the health websites they've been looking at.
Yeah, that's a really common situation and totally understandable.
It is, isn't it? A situation many of you might find relatable.
Definitely. Seeing those changes in someone you care about, it naturally makes you want answers and, more importantly, figure out what you can actually do to help.
Exactly. So for this deep dive, we're focusing on two really critical areas for older adults: how to prevent falls, and also how to understand the normal cognitive shifts that can happen with age.
Right.
Our goal here is to pull out the most important information from the research we looked at and give you some practical insights, without getting bogged down in all the complicated medical jargon.
Okay.
Okay, let's unpack this, starting with falls.
Yeah, this is a huge issue. The data consistently shows that falls happen a lot as people get older.
Really? How common are we talking?
Well, think about this. More than 1 out of every 3 people over 65 falls each year.
Wow, 1 in 3.
And for about half of those people, it happens more than once, recurrent falls.
That's a really high number. And I imagine it's not just a little stumble we're talking about. It can have serious consequences, right?
Absolutely. Serious consequences. We're talking injuries like hip fractures, head injuries.
Oh, wow.
Which often mean trips to the emergency room, maybe hospital stays. And beyond the immediate sort of physical harm, falls can really limit someone's ability to get around, do everyday things. And sadly, they also increase the chances of needing to move into, say, a nursing home.
So what's actually causing these falls? Is it just, a natural part of getting older, becoming less steady?
Well, in most cases, it's not just one single thing. Falls usually happen because of a combination of factors.
A combination.
Yeah. We often talk about predisposing factors. These are often the long-term health conditions, and then precipitating factors, which are more immediate things, like something in the environment or their current state.
Okay. So what kind of long-term health issues make someone more likely to fall?
Well, the research, especially one key article, points to several conditions. Things like arthritis, which obviously affects movement and balance.
Makes sense.
Depressive symptoms, too. Orthostasis, that's when you feel dizzy or lightheaded when you stand up suddenly because your blood pressure drops.
Right. I know that feeling sometimes.
Yeah. Also, impairments in thinking, vision problems, issues with balance itself, changes in how someone walks their gait, and just general muscle weakness, all significant factors.
And medication, I think the listener mentioned that too.
Yes, and interestingly, taking 4 or more prescription medications also greatly increases the risk.
4 or more. That really jumps out. And I guess the more of these risk factors someone has, the higher their chance of falling.
Exactly. The numbers really bear this out. One study found the risk goes from only about 8% for older adults with none of these risk factors, all the way up to a staggering 78% for those who have 4 or more.
78%, that's huge.
It is. So the crucial insight here really is that these risks, they compound each other. They don't just add up.
Right.
So identifying and addressing even 1 or 2 could significantly lower the likelihood of a fall.
And back to the medications you mentioned, taking several is a general risk. But are there specific kinds of drugs that are more strongly linked to falls?
Yes, definitely. There are certain classes of medication with a stronger connection. Things like serotonin reuptake inhibitors, tricyclic antidepressants, those can affect balance.
Okay.
Also, certain meds for mental health conditions, neuroleptics, benzodiazepines, often used for anxiety or sleep,
Right.
anticonvulsants, and even some specific drugs for heart rhythm problems. Class IA antiarrhythmics, they've all shown a link.
So for our listener, the takeaway isn't trying to diagnose their parent, but understanding that the types and number of medications are a key thing to discuss with the doctor.
Precisely. It flags it as an important area for conversation.
It sounds like managing medications for older adults can be a real balancing act then. You're trying to treat one issue, but maybe increasing the risk of something else, like a fall.
That's one of the big challenges, absolutely. Doctors are often, focused on managing individual diseases, maybe not always seeing the whole picture of these complex situations like fall risk.
Mm-hmm.
And with MEGs, it's always about weighing the benefits against the potential downsides. And falling is a really common side effect or adverse event for many drugs.
So if it's this complicated mix of factors, what's the most effective way to actually prevent falls? Is there a proven approach?
Yes, there is. The research really points to something called a multifactorial assessment, followed by targeted interventions.
Okay, multifactorial assessment and targeted interventions. What does that mean in practice?
It means looking comprehensively at all the possible things contributing to someone's fall risk, all those factors we just discussed, and then putting specific strategies in place to address those individual risks you found.
And does it work?
It does. Studies show this approach can reduce falls by, well, a significant amount, somewhere between 25 and 39%.
That's a really encouraging reduction. So what are the main parts of these successful interventions? What do they actually do?
Well, one of the articles had a really useful table, Table 1. Key components include a careful review and, where possible, reduction of medications. That's crucial.
We keep coming back to meds.
Yep. Then there's training to improve balance and gait, how someone walks, plus exercises specifically to strengthen muscles for better stability.
Yeah.
Checking and managing blood pressure changes when standing up, that orthostasis we mentioned. Making changes to the home environment to remove hazards like loose rugs or poor lighting.
Right, practical stuff.
And finally, targeted medical and cardiovascular assessments to catch any underlying issues contributing to the falls.
It makes so much sense that figuring out why someone fell before would help prevent future falls.
Absolutely. Looking closely at the circumstances of previous falls can reveal those immediate triggers, those precipitating factors.
Like what?
Was there a loose rug? Were they rushing? Were they feeling unwell? Had they just started a new medication? Identifying these helps tailor the prevention plan much more effectively.
So, if someone, like our listener, is worried about falls, what kind of specific assessments and management steps should they know about or maybe ask the doctor about?
Okay, well, another table in that article, Table 2, gives a great summary. First, like we said, review past falls and modify the environment or activities accordingly.
Okay.
Then a really thorough medication review, including over-the-counter stuff, aiming to minimize side effects, especially from psychotropic meds, those affecting the brain.
And reducing the total number.
Reducing the total number of meds, if it's safe to do so, often helps too. Vision check is important. Good lighting, correct glasses, maybe seeing an ophthalmologist. Assessing that postural blood pressure, and if it's an issue, managing it, maybe adjusting meds, ensuring hydration, possibly compensatory strategies like standing up slowly, maybe pressure stockings.
Right.
Then assessing balance and gait. There's a simple test called the Get Up and Go test.
The Get Up and Go test, that sounds like something a doctor could easily do in the office.
Exactly. It gives a quick snapshot. And interventions might include treating underlying causes, reducing meds that impair balance, environmental changes, or physical therapy for assistive devices and training.
What else is assessed?
A targeted neurological exam looking at things like proprioception, that's your body's sense of its position in space,
Right.
and cognition, thinking abilities.
Well,
Also, checking the muscles and bones in the legs and feet.
okay.
If there's concern about fainting or heart rhythm issues, a targeted cardiovascular exam, maybe a cardiology referral, and definitely a home hazard evaluation.
You mentioned that the risk really starts to climb after age 70.
Yes, fall risk and the number of risk factors tend to increase significantly after age 70, and even more so after 75.
And you stressed earlier that just doing the assessment isn't enough. It has to lead to action.
That's such a critical point. Studies are clear. Multifactorial assessments that aren't linked to specific targeted interventions just aren't effective in preventing falls. It's the follow-through, the action taken based on the assessment that makes the difference.
You mentioned proprioception in the neurological exam. Can you explain a bit more why that's important for balance? How does that work?
Sure. Proprioception is basically your body's internal GPS, knowing where your limbs are, how you're positioned, without having to look.
Okay.
As we age, this sense can become less accurate, less sharp, which obviously contributes to balance problems.
And how would a doctor spot that?
Well, one sign might be if someone's walking, their gait gets noticeably worse when they close their eyes, but maybe improves if they lightly touch a wall for support.
Oh, I see.
So a doctor might do simple tests for this. And if it's identified as an issue, physical therapy can often help improve it.
Are there other medical tests that might come into play sometimes when looking into falls beyond the physical exam?
Sometimes, yes. Simple blood tests to check things like vitamin B12 levels or thyroid function might be done, as deficiencies can sometimes contribute to balance or neurological issues.
Okay.
More extensive tests like, say, brain scans, neuroimaging, or heart monitoring are usually reserved for specific situations.
Quack.
Like if someone had a head injury from a fall, or if they show new specific neurological signs suggesting something like a stroke, or if there's a high suspicion of seizures.
The heart monitoring.
Maybe if there's a strong suspicion of an arrhythmia causing fainting or falls, but it's used cautiously. These ambulatory heart monitors can sometimes give false positives or negatives in older adults, so it's not a routine thing for all falls.
We also talked about that tricky balance with medications, the benefits versus fall risk. Are there practical ways doctors approach this?
Yeah, it's a constant clinical judgment call. The research does suggest, though, that it's often possible to safely reduce the number of medications someone takes, sometimes called deprescribing.
Deprescribe.
Exactly. The key is a careful review. Why is each medication being taken? Do the benefits still clearly outweigh the risks, including that fall risk? It takes careful consideration and usually a conversation with the patient.
And what about the potential link between falls and actually fainting, syncope?
There can definitely be an overlap. Some falls are actually due to a brief loss of consciousness. Interestingly, there's some preliminary data suggesting that for certain people with recurrent unexplained falls who also show a specific slow heart rate response during a test called carotid sinus stimulation, getting a pacemaker might actually reduce their falls.
Interesting. But still early days for that.
Still being investigated, yes,
Yeah.
but it highlights the potential connection.
So boiling it down, what's the main message for healthcare providers when it comes to fall prevention?
The guidelines really emphasize that all patients age 75 and older, and maybe even 70 plus if they have other risk factors, should be routinely asked about falls and screened for risk factors.
Ask the question.
Ask the question. And then, if indicated, use those comprehensive multifactorial assessment and targeted intervention strategies. That's the most effective approach we have right now.
Okay, let's circle back to the specific situation that prompted this deep dive.
Yeah.
The listener's 79-year-old mother with heart failure, arthritis, depression, sleep issues, who's fallen twice.
Yeah.
Based on everything we've discussed, what kinds of things might her doctor consider?
Right, applying this to her situation. Well, several things come to mind. First, a really detailed look at the circumstances of those two falls. When, where, how, what was she doing? To look for those precipitating factors.
Okay.
Then a careful evaluation of her antidepressant. Is it providing significant benefit? And how does that weigh against its potential contribution to fall risk? That's a nuanced conversation. It would likely be a good idea to strongly encourage her to stop taking any over-the-counter sleep aids or allergy medications, as those often have side effects that increase fall risk, especially in older adults.
Right, the antihistamines and things.
Exactly. Given her heart failure is stable, it might be possible to cautiously trial a lower dose of her diuretic or other heart medications, especially if she experiences that orthostatic dizziness when standing.
Carefully, though.
Very carefully with monitoring. And of course, ensuring she maintains adequate hydration, balancing that with her heart failure management.
That provides a really clear picture of how multifaceted fall prevention needs to be.
It really does.
Okay, let's switch gears now and talk about the other concern our listener raised. Age-related cognitive decline. I know this can be a sensitive topic for families.
It absolutely can be. And I think it's so important to start by reassuring people that some changes in thinking and memory are a normal part of getting older.
That's key, isn't it?
Yes. Having occasional minor memory slips, like where did I put my keys, or forgetting a name momentarily, doesn't automatically mean someone has dementia or is going to develop it.
And there are things people can actively do to support their brain health as they age, right?
Right.
It's not just inevitable decline.
Definitely not inevitable. And yes, the research strongly emphasizes how important maintaining good cardiovascular health is. What's good for the heart is good for the brain.
We hear that a lot.
And staying physically and mentally active, especially starting in middle age, can really help delay significant cognitive decline later on.
So proactive steps in midlife can pay dividends later.
That seems to be the case. The fundamental insight is really about that heart-brain connection. But it's also important to remember that normal aging does involve some neurological changes that can affect how we think. That's different from dementia, which is a disease process.
When are some good times, maybe opportune moments, to actually check in on someone's cognitive function as they get older?
Yeah, there are several natural points. During a cardiovascular risk assessment, for instance, or maybe after a major medical event like a stroke or even a significant illness or surgery.
Okay.
Times of transition can also be relevant retirement, maybe loss of a spouse. These can be times when changes might become more apparent or when it's just a good time to check in generally.
And the ways to keep our brains healthy, you mentioned heart health, physical activity, are they basically the same things we do for our overall health?
Very much so. The focus is on keeping your cardiovascular system healthy, being active physically, mentally, socially, culturally, and managing any existing health conditions, comorbidities, really well.
And starting early is best, but it still helps later.
Exactly. Starting those healthy habits in midlife probably gives the biggest long-term benefit for brain health, but making positive changes can still be beneficial at any age.
Beyond lifestyle, are there other proactive steps people should consider as they age, thinking about cognition?
Yes, absolutely. It's really crucial to encourage older adults to engage in future planning.
Future planning, like finances.
That's part of it, but also thinking about healthcare wishes, what we call advanced care planning, discussing preferences for future medical care while they're still fully able to.
Okay.
And also establishing an enduring power of attorney, deciding who they trust to make decisions for them, both personal care and financial, if they become unable to do so themselves later on.
Those sound like really important, though maybe difficult conversations to have.
They can be, but having them proactively is so much better than waiting for a crisis.
Let's talk a bit more about what's actually happening in the brain during normal aging that affects thinking. What changes occur?
Well, several things happen gradually. The brain tends to shrink slightly in volume. The neural networks, the connections between brain cells, can become a bit less efficient.
Less efficient.
Yeah, communication might be a bit slower. There's also some natural loss of neurons and synapses, the actual connection points. Changes in blood vessels supplying the brain and how the brain uses energy, its metabolism, also occur. And there tends to be a low level of increased inflammation.
Wow, quite a few things.
And lifestyle factors can play a role too. For instance, sometimes after retirement, levels of physical, social, and cognitive activity might decrease, which can also contribute.
And when do these changes start? Is it only in old age?
Actually, many of these brain changes start subtly, much earlier, even in our 20s and 30s. They just become more noticeable functionally in later decades.
I've heard terms like crystallized versus fluid intelligence. How do those fit into aging?
Ah, right. Those describe different types of cognitive abilities that age differently. Crystallized intelligence refers to our accumulated knowledge, skills, and vocabulary things learned over a lifetime.
Okay.
This generally tends to improve until around age 60, and then stays relatively stable, plateauing until maybe around 80.
So wisdom, in a sense.
You could think of it that way, accumulated experience and knowledge. Fluid intelligence, on the other hand, involves things like problem solving, abstract reasoning, processing speed, and learning new information quickly.
And that changes differently.
Yes. Fluid abilities tend to show a slow, gradual decline, starting from around age 20 onwards. A key reason for this is often a general slowing in processing speed.
So practically speaking, an older person might have a vast vocabulary, but take a bit longer to learn how to use a new smartphone.
That's a pretty good analogy, yes.
What about multitasking? I feel like that gets harder for me already.
Well, that relates to something called set shifting, our ability to flexibly switch our attention between different tasks or mental sets.
Okay.
This ability does tend to decline with age. That's why multitasking often becomes more challenging, and older adults might find themselves more easily distracted by irrelevant information.
Makes sense. Now, memory, that's often the biggest concern. What specific changes happen with different types of memory during normal aging?
Right. Memory isn't just one thing. Different systems are affected differently. Working memory, that's like our mental scratch pad, holding and manipulating information for brief periods, that tends to decline. This can make complex tasks harder and also affect how well new information gets encoded into long-term memory.
So trouble learning new things.
That can be part of it, yes. Perspective memory also often declines. That's remembering to do things in the future, like remembering to take medication or attend an appointment.
The remembering to remember task.
Exactly. Episodic memory, which is our memory for personal events, what you did last Tuesday, your last vacation, that remains relatively stable overall, but the recall might become less detailed or accurate over time. Interestingly, older memories often seem more persistent than recent ones.
And other types.
Semantic memory, our general knowledge of facts, concepts, word meanings, holds up quite well, as does procedural memory for skills like riding a bike or typing. These might show some decline very late in life, but are generally preserved.
So those common experiences, maybe having more trouble learning a new complex skill, occasionally misplacing things, that tip of the tongue feeling, trying to find a word, forgetting a task you meant to do. Those are generally considered part of typical age-related memory changes.
Yes, those sorts of things are common and generally fall within the range of normal aging.
But, and this seems crucial, dementia is not a normal part of aging.
Absolutely crucial. Dementia is not inevitable. It's not normal aging. It's a syndrome caused by specific underlying brain diseases or pathologies that go beyond the changes of normal aging.
What's the key difference then, functionally?
The key difference is functional impairment. In dementia, the cognitive decline is severe enough to interfere significantly with a person's ability to perform everyday activities, independently managing finances, driving, cooking, personal care. And importantly, dementia is typically progressive, meaning it gets worse over time. Normal age-related changes generally don't prevent independent living.
It must sometimes be difficult, though, especially in the early stages, to distinguish between what's normal aging and the very beginnings of a dementia process.
It absolutely can be. Our understanding of the very subtle, earliest changes in both normal aging and dementia is still evolving, and there can be overlap. Sometimes both processes might even be occurring simultaneously.
Age itself is the biggest risk factor for dementia, though, isn't it?
Yes, age is the strongest known risk factor. The prevalence, the likelihood of having dementia, increases significantly after age 60, and especially after 80 or 85.
But it's not guaranteed.
Not at all. It's important to highlight studies of centenarians, people living past 100. Many reach that remarkable age without developing dementia, which shows it's not an inevitable consequence of living a long life.
When should someone think about initiating a conversation about brain health with their doctor? What are some triggers?
Well, there are lots of good opportunities. When a patient just asks for general health advice, during those cardiovascular risk assessments we mentioned, when managing chronic conditions often linked to brain health like diabetes, depression, or atrial fibrillation, during major life transitions like retirement, after a significant medical event like a fall or delirium, even during routine checks, like for a driver's license renewal in older age.
And what if the patient or family brings up concerns directly?
Absolutely. If the patient themselves or their partner or a family member expresses concerns about memory problems, confusion, changes in personality, or maybe safety issues at home, that's a clear indication to explore things further.
What's the first step for a doctor if concerns about thinking abilities are raised?
The initial focus is really on gathering a good history. Talking to the patient, of course, but it's often very important to also get input from a family member or someone who knows the patient well.
Why is that?
Because sometimes the person experiencing the cognitive changes may lack insight or might minimize the difficulties they're having. A family member can often provide valuable observations about changes they've noticed over time.
And what is the doctor listening for during that conversation?
They'll be paying attention to how the patient answers questions. Is there hesitation, difficulty finding words, trouble recalling recent events accurately, or keeping details in the right sequence? How is their overall communication?
And based on that history, they decide if more formal testing is needed.
Exactly. That initial conversation and history helps determine whether a formal cognitive assessment is warranted.
You mentioned some brief assessment tools earlier, like the 6CIT or GPCRG.
Yes, those are short screening tools. If the history raises concerns, or if screening is being done routinely, tools like the 6-item cognitive impairment test, 6CIT, or the General Practitioner Assessment of Cognition, GPCOG, which includes informant input, can be useful initial steps.
And if those suggest a possible issue?
Then more comprehensive, though still relatively brief, assessments might be used, like the Mini Addenbrooke's cognitive examination, often called the Mini AC or MACE. These give a broader picture of different cognitive areas.
Is it important to follow up, even if the initial assessment seems okay?
Yes, that's often a good idea. Offering a follow-up appointment, perhaps in 6 months or a year, for reassessment can be very reassuring for the patient and family. It shows their concerns are taken seriously, and it allows for monitoring changes over time, potentially catching any significant decline earlier.
Okay, let's shift back to those lifestyle strategies for brain health. We talked about physical activity. What are the specific recommendations again?
Regular physical exercise is definitely encouraged. The general aim is for at least 2 to 3 sessions per week. The guidelines often suggest accumulating at least 150 minutes of moderate intensity activity per week.
Moderate intensity being?
Like brisk walking, swimming, cycling, on level ground activities where your heart rate is up, you're breathing harder, but you could still hold a conversation. Or, alternatively, 75 minutes of vigorous intensity activity per week, like jogging, running, or fast cycling.
And doing more is better.
Generally, yes, more activity often brings greater benefits, as long as it's safe and appropriate for the individual's health status. And activities that involve social interaction, like group exercise classes, dancing, or even just walking with friends, might help people stick with it better.
What about diet and supplements for brain health specifically? Any magic bullets there?
Unfortunately, no magic bullets found yet. Right now, routine dietary supplementation with things like multivitamins, B vitamins, or omega-3 fatty acids isn't generally recommended specifically for preventing cognitive decline in healthy older adults.
Why not?
The evidence just isn't strong enough to show a clear benefit for prevention in people who aren't deficient. Of course, eating a healthy, balanced diet overall, like a Mediterranean-style diet, is always recommended for general health, which indirectly supports brain health.
Okay. What about alcohol?
Limiting alcohol intake is definitely advised. Excessive alcohol consumption is a known risk factor for cognitive impairment and dementia.
And staying mentally active. Puzzles, crosswords.
Yes, staying mentally engaged is important. The advice is really about keeping your brain active and challenged. This could involve reading, learning new things, hobbies, crafts, using computers, playing musical instruments, engaging in social activities.
Does it matter what kind of activity?
A variety of stimulating activities is probably best. And doing them more frequently might offer greater benefit, though some research suggests the benefits might fade if you stop the activity.
What about those commercial brain training games and apps? Do they work?
That's a common question. While they might improve performance on the specific game tasks, the evidence that they lead to broader improvements in real-world cognitive function or delay decline is currently quite limited or lacking. So focusing on diverse, real-world activities is generally preferred.
That's interesting. You also mentioned cultural aspects earlier.
Yes, it's important to consider a person's cultural background and beliefs. Different cultures might have different perspectives on aging and memory, and participation in culturally relevant activities and maintaining social connections within one's community can be very important for well-being and cognitive health.
What about other lifestyle factors? Smoking, marijuana.
Smoking cessation is strongly recommended. Quitting smoking benefits overall health and also reduces the risk of cognitive decline and dementia.
And marijuana.
There's evidence linking long-term heavy marijuana use, particularly starting in adolescence, with negative effects on cognitive function in midlife. More research is needed on its long-term impact, specifically on dementia risk later in life, but caution is generally advised.
We've talked a lot about individual actions. Can healthcare systems do more to support brain health and that future planning piece?
Absolutely. Healthcare providers can proactively initiate these conversations. Having things like checklists for discussion topics or even dedicated appointments perhaps with a practice nurse can be really helpful.
What would those sessions cover?
They could cover home safety, driving assessment and planning, identifying potential support needs, and importantly, those conversations about enduring power of attorney and advanced care planning, making it a routine part of care for older adults.
Can you just briefly recap why the enduring power of attorney and advanced care planning are so vital?
Sure. An enduring power of attorney, or the equivalent term depending on location, lets an individual legally appoint someone they trust to make decisions about their personal care, welfare, and/or property and finances if they lose the capacity to make those decisions themselves later on.
So it ensures their wishes are followed by someone they chose.
Exactly. And advanced care planning is the process of thinking about, discussing, and sometimes documenting wishes and preferences for future healthcare treatment in the event you can no longer speak for yourself. It helps ensure your values guide your care.
Both sound incredibly important for maintaining autonomy and dignity.
They really are.
One last practical point related to cognition. Driving. How does that fit in?
Driving safety is a major consideration. In many places, older drivers require regular medical assessments to confirm their fitness to drive.
And cognitive impairment is a factor.
Yes, significant cognitive impairment can make driving unsafe. Healthcare professionals have a responsibility to assess fitness to drive and, if necessary, advise the patient and potentially the licensing authorities if someone is no longer safe behind the wheel.
That must be a difficult conversation, too.
It can be very difficult, as driving often represents independence. It's important to approach it sensitively but clearly, preparing individuals with cognitive impairment for the eventual need to stop driving, unless safety is an immediate concern, which requires more direct action.
We've covered falls and cognition in depth. Are there other common health challenges specific to older adults that listeners should be aware of, things that might interact with falls or cognition?
Yes, absolutely. Geriatrics, the field focused on older adults' health, deals with a wide spectrum. As the global population ages, understanding these is key.
So beyond falls and memory issues.
Right. Conditions like Alzheimer's and Parkinson's disease become more prevalent. Stroke remains a leading cause of disability and a major cause of death in older adults.
What about senses?
Various eye diseases, cataracts, glaucoma, macular degeneration become much more common and can significantly impact vision, which in turn affects fall risk and independence. Dental health is another big one. Gum disease is very common, as is tooth loss, which interestingly has even been linked to dementia risk. Dry mouth, oral lesions too.
And general disability.
Disability often stems from major chronic illnesses common in aging. Heart disease, arthritis, COPD, those vision and cognitive impairments we discussed, foot problems, hearing loss. Often it's the combination of multiple conditions, comorbidities, especially over age 70.
What are the root causes?
Often a mix of lifestyle factors, things from earlier in life, lack of exercise, the chronic diseases themselves, sometimes malnutrition. But the good news is that rehabilitation, treatment, aids, exercise, nutrition, and awareness can help prevent or manage disability.
You also mentioned muscle weakness earlier, sarcopenia.
Yes, that age-related loss of muscle mass and strength. It's a natural process, often starting around age 50, but regular exercise, even simple things like walking and stair climbing, can really help counteract it and maintain strength.
Anything else common? Skin? Mental health?
Skin problems become more frequent: itching, various growths, hair loss, eczema. The skin itself changes with age, becoming thinner, and mental health remains important. Depression, anxiety are common alongside neurocognitive disorders. Factors like social support, chronic illness play a big role. Oh, and urinary incontinence is another frequent, often under-discussed issue.
It really highlights how complex health can become in later life. And it brings us back to medications again, doesn't it? Managing meds seems central.
Absolutely central. As we age, our bodies just process medications differently. Changes in digestion, body composition, circulation, and especially liver and kidney function mean drugs might be processed more slowly, hang around longer.
Leading to more side effects.
Exactly. Increased risk of side effects and also drug interactions because older adults are often taking multiple medications for multiple conditions. The stats are striking. Most older Americans take at least one prescription med. Many take 3 or more. They use a disproportionate amount of both prescription and over-the-counter medicines.
So what are the absolute must-knows for safe medication use in older age?
Key things include really understanding your health conditions and why you're taking each medicine. Keeping a comprehensive, up-to-date list of everything: prescriptions, OTCs, supplements, herbals, and sharing it with all your doctors and your pharmacist.
That list sounds crucial.
It is. Also, read labels carefully: dosage, timing, warnings. Try to use one pharmacy consistently if you can. They can help spot potential interactions. Store meds properly, check expiry dates, and importantly, speak up. Talk to your doctor or pharmacist if you have side effects, questions, or concerns. Don't just stop taking something without discussing it.
And alcohol.
Be very cautious about mixing alcohol and medications, especially as you get older. The combination can be much riskier.
Okay. Lastly, let's just circle back one more time to physical activity. We know it helps with falls and cognition, but what are the overall recommendations for older adults? Why is it so important?
It's incredibly important because being physically inactive is strongly linked to so many negative outcomes in older age chronic diseases like heart disease, diabetes, some cancers, increased risk of falls and fractures, functional decline, higher healthcare costs.
Whereas being active helps prevent those things.
Yes, the benefits of increasing physical activity are huge. Reduced risk of hip fracture, lower risk of many chronic diseases, slower cognitive decline, reduced depression, and ultimately reduced risk of dying from any cause.
And it's never too late to start.
Absolutely not. Research shows that increasing activity levels, even in your 70s, provides significant health benefits.
So what are the official guidelines again, generally speaking?
Most guidelines converge on similar recommendations. Aim for at least 150 minutes of moderate intensity aerobic activity per week.
The brisk walking level.
Right, or 75 minutes of vigorous intensity aerobic activity. Ideally spread throughout the week, maybe in bouts of at least 10 minutes.
And strength and balance?
Yes, muscle strengthening activities involving major muscle groups should be done on 2 or more days a week. And for older adults, especially those at risk of falls, exercises to improve or maintain balance are also crucial, recommended on maybe 3 or more days per week.
Like Tai Chi.
Tai Chi is a great example, often recommended for balance. And importantly, minimize sedentary time. Break up long periods of sitting with some movement.
So wrapping this all up, thinking back to our listener worried about their aging parent, What's the main takeaway message from this deep dive?
I think the main message is that supporting health, preventing falls, and promoting cognitive well-being as we age requires a really multifaceted approach. It's not just about one single fix.
Right.
It involves looking at the whole person, carefully reviewing medications, incorporating targeted exercises for strength and balance, making the home environment safer, actively engaging in brain-healthy activities, and staying physically active overall.
And it really comes down to understanding the individual's specific risk factors and circumstances to tailor those interventions effectively, doesn't it?
Precisely. What works best is a personalized plan. It starts with recognizing the potential issues, having those conversations, doing a thorough assessment, and then putting together a strategy that addresses that specific person's needs and risks.
This has been incredibly helpful, thank you. It really highlights how interconnected physical and cognitive health are, especially as we get older.
They absolutely are.
So, for our final thought for you, the listener, considering this deep dive into how our physical and mental health intertwine as we age, what small but perhaps significant lifestyle changes could potentially have the biggest positive impact on maintaining independence and quality of life, whether for yourself or for your loved ones. Think about that. We really encourage you to discuss these important topics: falls, cognition, future planning with your healthcare providers and your family members. Thanks for joining us for this deep dive.